All right, we're going to go ahead and get started. Hello, everyone, and thank you so much for joining us. The Southeast Mental Health Technology Transfer Center would like to welcome you to today's webinar event, Radical Introspection, Remembering the Person of the Therapist in the Therapy Encounter. My name is Emily Moore, and I will be moderating today's event. I am joined by the Southeast MHTTC Director, Dr. Ben Druss, who will be introducing our presenter. A few words about our center, the Southeast MHTTC, before we get started. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also note that our center, as well as the larger MHTTC network, use affirming, respectful, and recovery-oriented language in all of our activities. A few words about our center. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provide a unique lens through which we can address mental health priorities. We encourage you to visit our website, mhttcnetwork.org/southeast, to learn more about our center and our upcoming events. A few important notes before we get started today. This event is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments throughout the presentation using the chat feature. Please remember to select Chat with all attendees if you would like to share your thoughts with everyone. We have allotted time at the end of our presentation for Q&A. Please submit your question during that time using the Q&A feature at the bottom of your screen. Finally, for participants who are interested, a certificate of attendance is available for download upon completion of our SAMHSA required evaluation surveys. I'm going to go ahead and turn it over to Southeast MHTTC Director, Dr. Ben Druss, to introduce our presenter for today.
Thank you, Emily. So it's a real pleasure to introduce Dr. Nilaja Green. Dr. Green writes, speaks and engages at the intersections of individual psychological distress and collective sociocultural oppression. As an Atlanta-based licensed clinical and community psychologist, Dr. Green is certified in trauma-informed care and delivering specialized, culturally responsive trauma treatment to vulnerable populations such as military veterans, Black women, and members of the LGBTQ+ community through her private practice, Atlanta Trauma Therapy and Consulting. She's engaged in several community-level initiatives, including collaborating with the mayor of East Point in Atlanta to create community-level conversations addressing issues of race, class, history, and equity. Having made appearances on podcasts and in print media, Dr. Green strives to share her message of culturally relevant, holistic mental health practice on various platforms. In service to her profession, she supervises, writes, leads workshops and trainings, asking clinicians to cultivate their own radical introspective practice and to approach care of clients with greater cultural humility. Thank you again, Dr. Green. It's wonderful to have you here with us.
Hello, everyone, and thank you, Dr. Druss, for that introduction. I'm just going to kind of share my screen to get us started. Today, we are talking about radical introspection for therapists, an evolving framework. And I wanted to start our conversation by thanking everyone for coming into the room today. I know that we're all coming from our own activities. We have our to-do lists in our minds, and I'm just appreciating you taking time out to not only listen to me, but really to spend some time thinking more deeply about your clinical work and your clinical practice. So a bit about how I came to this framework. I am a trauma psychologist, and that means I spend a lot of time meeting people on some of their worst days after some of their worst events. But before I was a trauma psychologist, I was a trainee. I was an intern and a postdoc working in community mental health. And I found that I had a lot of skills and techniques in mind, but those skills and techniques did not often answer the sense of powerlessness that I sometimes felt when I was sitting across from some of the most under-resourced of our clients. Community mental health, as you know, is often a place where we see folks who are living with severe and persistent mental illness, co-occurring substance use disorders, dealing with environmental stressors like poverty, homelessness, lack of financial resources. Often these folks are isolated from family and friends. And here I am, an intern sitting before them, trying to find a way to connect. So the first thing I did was I consulted literature, I read books, I engaged in supervision, I talked to my peers. And I found that all of those pieces of wisdom were helpful to a point, which caused me to then focus inward, to start paying attention to the stories, the biases, the judgments, the places of openness and flexibility that were existing internally that I needed to spend some time sifting through. Under the guidance of Dr. John Strauss, who had a writing group called Writing About Patients as People, where he invited clinicians to come in and do some reflective writing about our patients, which really was reflective writing about ourselves. I came to understand more and more the power of reflective practice, and not only the power of reflective practice, but the necessity of reflective practice for clinicians. And so today is really the evolution of work that began at this point about 10 or 11 years ago. And so I'm inviting us all into a conversation where we deepen our own awareness of what we're bringing in to the therapy encounter. So you know a little bit about me, and I'd like to know just a little bit about you. I'm inviting you to drop into the chat one word that describes what you're bringing into this space today. Just checking in, and if you would oblige, just jotting down a feeling word that represents where you are today. And make sure you indicate in the chat that you are sending the message to everyone. Curious and present. Okay, we are overwhelmed and more curiosity. We're bringing in a sense of peace. Any other responses about what you're bringing into the room? We have some openness. All right. So collectively, this is the air that we're breathing. We're breathing in curiosity and peace, a sense of overwhelm and openness, a sense of presence. It's important for us to know what we're bringing into the room right now, but also, of course, in our therapy encounters. And so when we take a moment to check in with where we are and how we're doing, that allows us to be more present, which then allows us to not be so surprised when we might be triggered by something or when something might come up that we're having a reaction to. For some reason, I cannot get out of the chat. Stephanie or Emily, can you help me get out of the chat?
Hi, Dr. Green. Is there a X on the chat where you can just X out of it?
There was. Can you see the chat?
Nope, we can't see the chat, just you.
Okay, well then that's fine. I'll just
Awesome.
ignore it. So our objectives today are fourfold. This is what I'm hoping to do, and hopefully we'll have enough time to do all of it. I want to introduce mindfulness in the context of radical introspection, introduce the essential elements of radical introspection, discuss the relationship between radical introspection and clinical work, and also engage you all in a short reflective practice to give you a sense of how radical introspection works. And my hope is that today you're able to leave with a bit more of direction about how to really continue developing the self of the therapist in your work. So I wanted to also give us a mindful moment. And in this mindfulness moment, I'm inviting us to put feet flat on the floor if you can, allowing your shoulders to be down and back, allowing your spine to be comfortably straight. You're welcome to keep your eyes open if you like, or close them, whatever feels most comfortable to you. You might even move your head from side to side, just roll your shoulders back and forward, allowing yourself to just settle into your body. I was going to share a YouTube video, but I'll just talk us through it. Uncrossing your limbs and allowing your hands to relax in your lap, with your palms facing up towards the ceiling or down towards the floor. I'm inviting you to breathe. You don't have to change anything or shift anything in your breath, but just allowing yourself to notice the inhale and the exhale. Becoming really aware of where the breath is traveling as you're breathing in, and aware of the sensation of releasing the breath. Breathing in and out, and in and out, and in and out. Taking one last breath and returning to the space. So why talk about the therapist when we are talking about introspection and reflection and being clinically effective? Well, we have to talk about the therapist because it is our ethical responsibility, right? As the primary vehicle of the work, we are responsible for our own personal development to benefit the client and reduce the likelihood of harm to the patient. Unfortunately, therapy can do harm. While we might think of the more obvious examples, obvious boundary violations, for example, sleeping with your client, lying to them, not caring for fiduciary responsibilities, misdiagnosing, there are also other ways that therapists can not only not be effective, but actually be harmful. One of the ways is when we are in the room and our stuff is getting in the way, when our own discomfort with our emotions, when our own biases and judgments are showing up, when our blind spots are hitting up against the therapy encounter and we are not aware. Sometimes we don't even know that we're causing harm because our clients go away and never come back. Or they stay in therapy with us, but there seems to be a place that we can't get past. As therapists, we might move to the side of thinking, well, maybe it's something about them. Maybe they're resistant, or maybe they're just unwilling to change. But it's important for us to turn our focus on ourselves and ask, are there ways in which I am the bottleneck in this process? Are there ways in which I am interrupting the effectiveness and the connection in the therapy relationship? As people who are bound to continue our professional development, we can think about the words of Yalom, who tells us that psychiatry is a strange field because, unlike any other field of medicine, you never really finish. Your greatest instrument is you, yourself, and the world of self-understanding is endless. There are those who believe we can never really fully know ourselves, that there are parts of us that will remain in the shadows or remain hidden to our conscious minds. Radical introspection says it is still our job and our duty as responsible clinicians to try to know as much about ourselves as we can, and to recognize that we are evolving selves, which means doing some introspective work 10 years ago, 5 years ago, may be nearly irrelevant to who we are today. So the process of radical introspection is one that is ever evolving. It is one that doesn't just stop and doesn't just end after we've completed graduate school, finished internship and postdoc, or have been in our careers for a long period of time. Doing our own work is also clinically relevant. William James tells us that whenever two people meet, there are really 6 people present. There is each person as they see themselves, and each person as the other person sees them, and each person as they really are. I think about this in the same way that I think about hearing my own voice. I remember having the experience of listening to a recording of my voice played back to me. Now, we all have a sense of how we think we sound in our heads. And many times when our voices have been recorded and reflected back to us, we may have the question of, well, who is that? And there was actually a recent NPR podcast, Hidden Brain, that talked about how difficult it often is for us to hear our voices played back to us. And there were some participants in the study who actually could not distinguish their voice from someone else. We have our own idea of who we are in the world, and we might think that other people are seeing the same thing we think we're projecting. But in fact, other people are seeing us through their lens, just as we are seeing other people through our own lenses. And so it's important to check out which lens we're using, what's informing that lens, because that not only shows up outside of the therapy room, but it most certainly shows up inside of the therapy room. The psychiatry literature and psychology literature over and over again is showing us the same things when it comes to the effectiveness of therapy. Regardless of theoretical orientations, we know that the actual relationship is one of the most, if not the most important part of the clinical encounter. After all, nothing happens when people don't feel safe, and that extends to therapy. If our clients don't know that they can trust us, if they don't have confidence in us, if they don't feel like they can rely on the therapy relationship to empower them, give them direction, then our clients won't be able to follow whatever techniques and skills we offer them. So, part of what we are paying attention to when we're looking at our job as therapists in creating the relationship are the characteristics that we are meant to embody and the skills we are meant to use. Although the therapist and the client are both responsible for the relationship that's developing, the therapist really is the one that is laying the foundation for what I like to call the therapy encounter, the therapy container. Whatever work is happening in therapy happens within this container that is initiated by the therapist. When I talk to clients about our work in the therapy relationship, sometimes I talk about therapy like a lab, that therapy is a place where we learn skills, where we try out hypotheses, where we feel out what might work or what might not work. And then their job is to go into the world and to practice between sessions, to gather information about what happens when they challenge their thoughts, try to accept something that they've been having trouble accepting, work on managing their emotions differently. And then we come back to session and we examine the data. We find out how that went. We think about how other people reacted to them and how they reacted to themselves. And so because of that, I know that my job as a therapist, I know that our jobs as therapists is to create a safe container, a compassionate container, a container that also offers the opportunity to challenge and push and help to facilitate whatever skills and techniques we are bringing into the room. And so we do that by being and also by doing. Our job in the being is to demonstrate flexibility, honesty, respect, trustworthiness, confidence, warmth, genuine interest, and openness. And I would love to say that every therapist has these skills inherently, walks around the world with flexibility, honesty, respect, trustworthiness, interest, openness, and warmth. I would also love to say that if we don't start out this way, once we go through our graduate training, we come out on the other side with these characteristics embodied in us. However, I think it's safe to say that we are all on a spectrum. We do some of these things well and maybe naturally, and we do others of these things maybe not so well. So when we talk about flexibility, we're really talking about being adaptive, being responsive, allowing ourselves to move in the direction that the therapy is taking us. So when I was in training, I used to spend a lot of time putting together my worksheets and really planning out every session and thinking very critically about what my client might say and how their reactions might show up in the room. And then I would get into the clinical encounter or into the therapy room, and my client would say, "Oh my gosh, my dog died." And then the whole session would be about how the client is responding to the death of their dog, as opposed to all the worksheets that I put together. And I started to learn the importance of being able to be responsive in the moment while also holding the thread of the work. We did a little mindfulness earlier. One of the reasons that we did mindfulness in this moment was so that we could come to the present, because it is in the present moment and from the present moment that we learn responsiveness. I can't be responsive to what's happening in the room if I'm just thinking about the worksheets that I prepared and how we need to get through this worksheet so we can get to the next worksheet so we can do this in the next session. I am having to be grounded in the present moment so I can demonstrate flexibility. Honesty. Honesty might seem quite straightforward. Honesty, don't lie. However, it's not always as straightforward as it seems. Of course, obviously and blatantly deceiving someone, okay, that's dishonest. But sometimes we might show ourselves to be dishonest without meaning to, leaving out certain information, thinking that we are telling the truth without knowing that we're masking certain things, or telling part of the truth because we're afraid of telling the whole truth. Honesty in the therapy encounter is also about how we think about the ways in which our clients show up to us in an honest way and the ways in which they show up to us in maybe dishonest ways. And how do we judge that? How do we determine what to do when we find out that a client maybe hasn't told us the truth, or maybe isn't telling other people in their lives the truth? I used to work at the VA, and in my work at the VA, there was a clinician there who had some thoughts about truth and deception and veterans. And the rest of the team found ourselves thinking really critically about how this clinician was engaging with whether or not clients were telling them the truth or telling us the truth. And so you might think about, what is the role of honesty and deception in the therapy encounter, and what judgments are you bringing to that? Demonstrating respect. Again, working at the VA, when I first got there, I had a caseload of easily 200 veterans, which means I had a lot of opportunity to encounter folks who had very different values than I did in some cases, which really had me thinking about how to show up respectfully and in genuine respect. Because some of the encounters that I had, some of the beliefs that people expressed were very, very different than some of the beliefs that I may hold quite dear to my heart. So really thinking about, how can you show up respectfully, especially with clients that you have trouble connecting to or whose beliefs or values seem so different from yours? Trustworthiness. As clinicians, we have to be able to demonstrate that we are reliable, that we are consistent, that we will do what we say we will do, or that if we don't do what we say we will do, that we can be accountable, that we can apologize when necessary, that we can really listen to and take feedback to heart. All of those things demonstrate trustworthiness, which of course is really important in demonstrating safety. Confidence. Confidence we can think about as evolving. My confidence in being a therapist 10 years ago was not the same as my confidence being a therapist 5 years ago, and not the same as my confidence in being a therapist now. And I don't consider confidence as something to achieve and then it's done, because there will always be the opportunity for a new experience, a new client, a new challenge. So really paying attention to the ways in which, and the areas in which we feel confident and the ways in which we might not. Warmth. thinking about what it means to engage with our clients from a place of warmth and how often we engage in our lives with warmth. Because if we are resistant and somewhat distant and not very warm in our personal lives, that might be kind of a heavy lift to develop genuine warmth and showcase genuine warmth in the therapy encounter. So really paying attention to how can I show up in genuine warmth, especially if that's something that doesn't come very naturally to me. Genuine interest. If you are not interested in what your clients are telling you, you might ask yourself, what's going on with me? If one depressed person is the same as any other depressed person, if one anxious person might as well be the 50 other anxious people that you saw, if, okay, I know how this story is going to end, comes up for you over and over again, you really want to check in with yourself. Every client is a universe unto themselves. Every client is a collection of stories. And where we lose our curiosity about our clients' experiences, we lose connection. Openness. Similar to flexibility, openness is really the ability to create a space where a person can show up as they are, and they can do so without being concerned about your judgment. Now, our clients may be concerned about what we will think about them, but hopefully that's not because we have done something to make them believe that we'll judge them, but rather that's more about their internal dialogue. So really paying attention to the ways in which you are open or closed and pushing yourself to be more open. Those are the what skills, if you will, about what we need to embody as therapists. And these are the how skills. How do we show our clients that we are engaged, connected, interested in their growth and development? We use exploration, which really requires some level of curiosity. As a trauma therapist, I've been trained in cognitive processing therapy. And cognitive processing therapy utilizes Socratic questioning. And I have to admit that sometimes I've had trouble with these open-ended questions that seem to lead clients wherever they will go. Because often when a survivor comes to me and they say things like, I should have known that person was going to assault me, I do have an opinion about that. I often do have a sense that says, well, how could you possibly know that someone's going to harm you? I don't say that out loud, but often that's what I'm thinking. And so as I'm going through the process of Socratic questioning, which is what CPT requires, and I'm asking questions like, okay, well, tell me about the connection between how this person was behaving and what you think you should have known. Or explain to me how self-blame comes up for you. As I'm asking those questions, I have to really check myself to make sure that I am coming from a place of curiosity and really wanting to know the conclusions that my clients are drawing, as opposed to waiting for an opportunity to say, see, this is proof that you couldn't have known. See, this is proof that you are not to blame. And so really coming to exploration from a place of curiosity and openness, and also knowing the things inside of you that might block that process. Reflection is another important skill to demonstrate. I very rarely reflect back to a client exactly what I've heard them say. There's not very much parroting that happens. Often when I'm engaging in reflection, I'm doing so by paraphrasing and then adding a piece. And that might sound like, I heard you say that you felt really isolated in that moment. And the more I've heard you talk about this, what really comes up for me is a sense of emotional abandonment. What do you think about that? So I am letting the client know that I heard what they said, but I'm also adding this other piece and checking it out with them to see whether or not that piece that I've added actually deepens the conversation and gets us more quickly to the heart of the matter, or if it's completely erroneous. And of course, this really speaks to something that we're going to get to right after the past therapy success of having accurate interpretation. One of the ways that we can make sure that we are interpreting something as accurately as we can is to check it out with the client, to make sure that not only we're hearing what they've said, but that our understanding of what they've said really feels like it fits. Noting past therapy successes. So I have often been surprised when clients come in and they say, I don't know if therapy is helping. And I'm able to say, okay, well, what makes you say that? And I'm noticing that 6 months ago, you weren't even talking to your mother. And in our last session, you came in and you told me about how you had really revealed and disclosed all of these aspects of yourself to your mother that you hadn't even considered doing 6 months before. And then clients' faces often light up as they are able to recognize for themselves that they really have been engaged actively in this process of movement and self-development, and that their lives are shifting and changing as they are doing so. But sometimes it's our job to reflect to clients what we have seen in them that maybe they have not seen in themselves. Facilitating the expression of affect is also very important, allowing the client to know that the container that you have created is a safe space for them to express the myriad of emotions. Now, of course, this doesn't happen just by saying, it's okay to cry here, because that reminds me of when people say things like, you can trust me. Often when someone says, trust me, we look at them sideways like, I don't know. It isn't just in what you say, it's also in what you do. When your client is expressing uncomfortable emotions, how do you respond? Do you fidget in your seat? Do you lean back and away from them? Do you quickly rush past those uncomfortable emotions to emotions that might feel more comfortable with you? In my clinical supervision experiences, I work with graduate students, and we use a radical introspective method. And I had one experience with a graduate student who had a client where every time the client expressed something about themselves that may have been negative or pejorative, the supervisee said something positive, right? Oh, but you're really trying. Oh, but you're so strong. Oh, but look how talented you are. Oh, but look how smart. And I had to have a conversation with the supervisee about where that impetus, that impulse was coming from. What was happening for them when the client was expressing these thoughts about themselves? Where was the discomfort? And in doing that, we were really able to get to the bottom of how that action was interfering with the therapy relationship. And the supervisee was able to create more space for the client to show up and explore what those thoughts were about for the client, what those emotions connected to those thoughts were about. So in that case, the supervisee was really kind of a bottleneck in that work. But through the radical introspective framework, we were able to clear that bottleneck, which ultimately deepened the therapy relationship and also allowed the client to do some really important work that they needed to do. Which also takes us to the last piece of attending to the patient's experience. In order for us to really know how the relationship is going, in order for us to really know reasons that our clients may or may not be using the skills and techniques that we're offering, we have to pay attention to what's going on. We have to pay attention to what we're seeing and what we're not seeing. And sometimes this means having really explicit conversations about the therapy relationship. At the end of each of my sessions, I ask the same things. I say, do you have any questions, comments, or concerns? And is there anything today that I missed? And I'm asking those questions because I really want to have a sense of how my clients are doing. I want them to know that I care about how they're doing. And I want them to know that I am open to feedback. And sometimes I have to say to them, no, I really mean what I'm saying. I really do want feedback from you because I want them to know I'm being genuine. So what does mindfulness have to do with radical introspective practice? As we have talked about the characteristics that therapists need to embody and the skills that we need to use, mindfulness really forms the foundation of that work. We can think about mindfulness through the traditional Western framework, where many of us know of mindfulness as a stress management technique, as something we can use to decrease symptoms of anxiety or depression or suicidal ideation. We also know of mindfulness and chronic pain and how mindfulness really can help to reduce the intensity of the experience of chronic pain. And all of those consequences and results are really important. They also don't necessarily speak to the original intention of mindfulness meditation. Mindfulness meditation comes from a history that is about 2,500 years old. And mindfulness meditation is really couched within a framework for ethical living. Mindfulness meditation is designed to be an internal practice for external good. And what that really means is that through the practice of learning more about oneself through meditation, you begin to develop wisdom, insight, awareness, but also to develop compassion. And compassion isn't the same as empathy. Empathy can be a really cognitive kind of experience where I understand what you're going through because I can put myself in your shoes. Compassion, on the other hand, can be translated to suffer with. Because compassion means that I have an emotional experience connected to what you're going through, and I also have the desire to do something to help alleviate your suffering in some way. And so through mindfulness practice, I become aware of my own places of pain and my own places of suffering. And because I am a human being in the world, I recognize that if I experience pain and I experience suffering, I know that you experience pain and you also experience suffering. So even if I have never experienced the kind of pain that you have, because I have experienced pain, I can connect with you from that place. Now, we can talk about this from a place of just kind of connecting to humanity in general, but we also can really talk about how important it is to be able to do that with our clients, to really come from a place not just of cognitive understanding, but emotional understanding, being able to meet our clients really where they are from a compassionate place. And mindfulness meditation gives us the practice of getting centered in ourselves enough that we can find our own compassion. We can think of the definition of mindfulness as full, flexible, non-judgmental attention to the present moment with willingness, curiosity, and openness. And so as you can see, even in the definition of mindfulness, we have some of the characteristics that therapists are meant to embody for effective therapy. Then, of course, we have radical introspection. The introspective practice of the therapist is the basis for all other therapeutic work. Now, of course, we all have our own orientations. We all have our own thoughts about what makes people change, what causes people not to change, how people get caught up in their own patterns and their behaviors. But if we don't start with us, if we don't know what our intentions are, if we're not clear about our values, if we don't know about our own biases, then we actually are missing so many pieces that can interrupt, interfere with even the clear expression of our orientations. So if we think of the therapy encounter as not starting with the client, but actually starting with us, if we recognize ourselves as a tool and instrument of the work, then we know we got to make sure our tools are in as best shape as they can be. Radical introspective practice is present-oriented and responsive because I may be thinking about what happened last week or anticipating what's going to happen next week, but it is only the present moment where the client exists and I also exist. And so in the present moment is where I can gain the wisdom that I need and the direction that I need in order to really connect with the client and know how to respond. In radical introspective practice, I examine my own thoughts and my own feelings, not just about the client, but also about my work with the client, who I am in the clinical encounter, who I am as a therapist in general. This inward looking is not just about my thoughts and my feelings, but it's also about my behaviors, the stories that I've told myself or have been told, the biases that I hold, the worldview that I walk around with, and my identities. Intersectionality is a concept that was introduced by Kimberly Crenshaw. And she introduced this concept to help us understand that we walk around the world not as one thing. I am not just a woman. I am African American, I am a woman, I am from Brooklyn, I am married, I am a psychologist. All of these identities, some of which are visible, some of which are invisible, are part of my experience of the world, which also means that my identities inform how other people respond to me, what discriminations and oppressions I encounter, as well as what privileges. So the radical introspective process doesn't just stop at what you're thinking and what you're feeling and what you're doing as a therapist, but it continues into really digging into what are my identities? How do I express them or not? How do I feel about them? How much do they inform who I am as a therapist? So reflective processes are not new. Reflective processes have existed for some time. The radical introspective method, although it was not actually drawn from reflective processes, it does draw on some of the same practices that you will see in practices like self-inquiry, reflective practice, the work, and even deliberate practice. One of the differences with radical introspection is that it is really designed for a clinician to improve the work of therapy. So it isn't just a evolving individualized practice to know more about oneself for the sake of knowing more, but it's knowing more about oneself for the sake of doing better and being better in our work. So here's the framework. We have radical introspection in the middle. It is informed by reflective writing, mindfulness, deliberate practice, self-inquiry, intersectional awareness, courage and willingness, and the person of the therapist. The radical introspective framework was really birthed out of my reflective writing experiences. Reflective writing has been shown to be very helpful for extending our emotional awareness, helping clarify our internal experience, and recognizing the stories that we tell ourselves and the stories that we live with. And so one of the hallmarks and one of the linchpins of radical introspection is reflective writing. We've already talked about mindfulness. Deliberate practice is the practice of repeatedly working on a particular area of weakness or vulnerability. In radical introspection, we don't really use the words weakness and vulnerability. We do use the idea of growth moments and growth opportunities. And the method doesn't focus there, but adds those pieces in as we are paying attention to the whole of the clinician. Self-inquiry, of course, is the process of knowing more about why one is doing what they're doing. And intersectional awareness is not only important for the person of the therapist, but also important for the person of the therapist as we relate to our clients. What are the identities that our clients are coming in the room with? And how are those identities informing their experiences of psychological and emotional distress? And how comfortable are we with talking about those things? So back to my experience at the VA, I was on the military sexual trauma team. And for me in Atlanta, the majority of veterans that I saw, easily 80 to 85%, were Black women. And there was a small portion of Black men that we would also see. And often when you ask questions about the traumatic experiences that our folks had, they would be pretty standard questions, right? So what happened? Where did this happen? How have you been noticing changes in your life since this happened? And through our work, we started to really pay attention to social identity and how social identity may have impacted their experience of the traumatic event, either before it happened or as they think about the event now. And so one of the questions that started to sneak into the work was, what, if any, identity factors of yours do you think had to do with the trauma experience? Which really opened the door for folks to say, you know what? Although this is what happened this time, there had been a pattern of treatment of me I've been passed over for promotions. I've been given kind of the worst jobs. I've been put on the front line or been given some of the most dangerous missions. And through understanding the social identity pieces, we actually had much more information about the impact of the traumatic event. Now, we wouldn't have been able to do that if we didn't pay attention to the intersecting identities of the client. And we wouldn't have been able to have that conversation without really paying attention to our own intersecting identities. And so intersectional awareness is really about me knowing my different pieces, me being able to see the different pieces of my client and being able to talk about that, which really comes to the courage and willingness piece. I think of therapy as this really exciting, dynamic experience, one that pushes and challenges the client, but also can push and challenge us. Push and challenge us to maybe stretch a little further than we had before, to maybe sit in discomfort a little longer than we might normally, maybe to consider a perspective that we hadn't considered, to really shift and be open to shifting and changing how we show up in the world and how we show up with our clients. And that often takes courage. Sometimes it can be risky to apologize to a client. It can feel risky. We're not sure how they're going to take it. Are they going to think that we're incompetent? Are they going to lose trust or faith in us if we admit that we made a mistake? So really thinking about how can we lean into courage and willingness? And of course, the person of the therapist. This work can be really difficult work to learn more about yourself, to think more about how you show up in your work and how your clients might be receiving you, even thinking about ways that you might be hiding certain things from your clients because you don't want them to know these things. And in the world of social media, many clients might know things about us that we didn't intend for them to know. I had a client come in many years ago and said, "Congratulations." And I said, "Congratulations." And they said, "Yeah, you just got married. I saw the pictures on some site that I didn't even know my pictures were on." So in this age of so much information being available about us without us necessarily knowing, it's even more important to pay attention to how we are viewing ourselves and the things that we would like or not like our clients to know. So the focus of radical introspective practice, we have certain areas that we hit. We pay attention to clinician values and orientation. And that's orientation in terms of how you think about change and the specific theoretical orientations you work with, but orientation more broadly, how you situate yourself as a clinician in the work. Do you think of yourself as an expert, as a teacher, as a guide, as a partner in the client's journey? Where do you place yourself? Vulnerability. How does a clinician deal with vulnerability in their own lives, and how do they deal with vulnerability in the clinical encounter? There are moments where the therapist's vulnerabilities may be exposed. Maybe one of your clients is dealing with something that you are also dealing with, right? A client is going through a divorce and you have just completed yours, or your partner has just come to you and said, "Actually, like, I'm done with this." Those are really vulnerable moments, whether the clients know it or not. How are you managing your own vulnerability? Intimacy and boundaries in the work. Some of our boundaries are absolutely informed by ethical responsibilities, but there are other boundaries that are not so straightforward. And those boundaries might really be informed by our own levels of comfort with touch, disclosure, emotional intimacy. And so it's important to investigate. So the boundaries that I set up in my work, are they flexible? Are they the same, regardless of who I'm talking to? How much are they reflective of how I deal with boundaries in my own life and my own stuff versus how much are they reflective of what the clinical encounter or the client might need from me? Emotional competence. I think of emotional competence as not only the awareness of what emotions I'm experiencing, but also the ability to regulate them, manage them, express them, and respond to them appropriately. And it takes time to develop good techniques for managing our own emotions. But emotional competence, I think, lends itself to confidence, not only in the therapy room, but in your life more broadly. We talk about the imposter versus the expert and developing self-trust. Sometimes we show up in the therapy encounter and we feel pretty confident that we know what to do and how to handle the distress that our clients are bringing to us. We know what techniques to pull from, what things to say. Other times we might show up and not be so sure. How do we deal with those moments of uncertainty? What's our default? Where do we go? Exploring identity, we've already talked about that with the intersectional awareness piece. Thinking about purpose and intentions. What is my purpose in the room? What am I doing here? What do I want my clients to get from me? What are my intentions in the work? And self-care. I think for clinicians, self-care is really uniquely flavored for us. Self-care could be a mani-pedi, it could be a yoga retreat, it could be spending time with our loved ones. But self-care also requires us to think about the impact of our clinical work, the impact of our clients on us. We have really strange jobs, I think, where part of our job, a really important part of our job, is to develop these really intimate relationships that are often one-sided with people who are in varying levels of distress in their lives. And due to our ethical obligations, we can't just go home and say, wow, partner, let me tell you what happened at the office today. This person did such and such and such and such. And then our partner helps us think through or demonstrates kind of empathy and compassion for us. Many of us, if we're not talking to our peers or we're not in supervision, we have to kind of manage these things on our own. So radical introspective practice says it is really important, necessary even, for therapists to develop a multi-level approach to their self-care in such a way that we attend to ourselves in the moment, we pay attention to how we are nourishing ourselves, we pay attention to how we're maintaining ourselves, and we also connect to fulfillment, meaningfulness, and joy. That those pieces of self-care are as necessary to the work as anything else. Because if we are not taking care of ourselves, we cannot show up as the kinds of therapists that we need to be. Can't maintain boundaries the way we need to, can't keep the space clear of our own challenges and issues. So this slide just really speaks to the ways in which radical introspective practice causes the therapist to turn those skills that we use with clients onto ourselves. Exploration, reflection, tracking the past success of clients and how that relates to us really being able to show up in presence with them, having accurate interpretations of their experiences, but also of our own, facilitating affect of the patient, which also means being able to facilitate our own affect, and attending to the patient's experience through, of course, the practice of attending to our own. And so this is just talking more about how radical introspection facilitates these particular pieces of the work. And I want to leave time for question and answer, so I'm not going to go into them, but because the slides will be available, you'll be able to read more about that. Here are some questions that I'd like you to consider. We won't have time to talk about them today, but these are just examples of the kinds of questions radical introspection utilizes in supervision and also in the development of the therapist. What makes you the kind of therapist you are? And describe your approach in 3 words. How do you want your clients to experience you? What is most important for them to learn from you? As you may notice, this isn't about theoretical orientation, but it really is more about you as a person and delving more deeply into how you as a person intersects with who you are as a therapist. The radically introspective therapist demonstrates these qualities because through the practice of self-reflection, you are able to become more able to be dynamic, to create safety, to navigate self-disclosure well, to be emotionally competent and confident, to recognize intersectionality within yourselves and others, to inspire growth and curiosity, to be courageous, self-trusting, collaborative, and also empowering. Thank you so much. I want to leave room for question and answer. These are just some information about how to contact me, and I will give it back over to Emily or Stephanie.
All right, thanks so much, Dr. Green. We still have a little bit of time for questions. So if anybody has any questions for Dr. Green today, please feel free to put them into the chat for her or into the Q&A feature at the bottom of the screen. And we'll give folks just a little bit more time just in case they're thinking of a question or typing it in. As we wrap up, Dr. Green, were there any closing remarks or comments that you would like to make before we move on to evaluation?
So I really thank everyone for being here, and hopefully the no questions doesn't mean I put everyone to sleep. But if you leave with nothing else, I'd like to just encourage you to be really aware, committed to, and attuned to your own experience as a therapist, and to know that that experience is showing up in the room. I had a conversation with one of my supervisees about compartmentalization and how she thought that the anger that she was feeling about her program had nothing to do with how she was showing up with her clients. And through our work together, she started to recognize, oh, wait a minute. Actually, maybe in that last therapy session, I did show up in this way and that way, and that was connected to this anger I'm feeling about something entirely different. So really becoming committed to and willing to think about the ways in which who you are outside of the room is showing up inside of the room.
I do see a few questions in the Q&A feature now, if that's all right. The first one being, how would you apply these principles in a crisis situation?
So my first question is if it's a crisis of the clinician or if it's a crisis of the client. Do we have any response to that?
No response to that that I see. It was an anonymous question.
Okay. So when I think about crises, I actually don't think about crises as a time to sit back and reflect. Often our brain really goes into survival mode when we are in crisis. And what we want to do in a crisis is, at the very least, not make anything worse. And so we want to find out what is needed, how we can address what's needed, if there are things that we need to accept in the moment, how we can act in whatever places of control and power that we have, and helping clients to see those same things in that moment. Radical introspection would be much more helpful when the crisis is over. So we can together look back on how did the client respond to the crisis, and how did I, as a therapist, respond? One of the places this often comes up is when therapists are trying to make decisions about whether or not to hospitalize a client, and how much of that decision is based on their own anxieties and their own worries, maybe even their past experiences related to clinical work, versus being responsive to what the client might need in the moment. And so in the crisis, we want to make sure that we're doing everything that we can to get needs met, to survive the crisis, to not make things worse. And after the crisis, that's when we will use our introspective lenses to pay attention to what was driving our behaviors and the behaviors of our clients in that moment.
Thanks so much. There's another one. Can you share some examples of self-disclosure that you have used? I think I get caught up in being so boundaried sometimes and am unsure of where that line might lay at times.
Absolutely. So most of my clients are people of color who often have questions for me. How long have I practiced? Why do I do the work that I do? Most of the questions are actually quite appropriate. Sometimes they ask me how old I am, or they try to gauge. One of my favorite questions is, why do I do this work? And I answer that kind of as honestly as I can. I don't always provide a lot of detail, right? Some of the reasons I do this work has to do with my own family history of kind of mental health challenges and substance abuse. And I might even say that. I might say within my own family, there have been experiences that have really contributed to how I think about the work and my commitment to the work. I might talk about what some of my values are and some of my approaches. And so self-disclosure, I think of as an opportunity to facilitate the conversation, the therapy relationship. So if I'm sharing something that's not going to facilitate the therapy relationship, then I probably won't share it, right? Like, I don't need to talk about my age. I don't need to talk about the fact that I have 2 dogs unless somehow it becomes relevant in the moment. But I think about self-disclosure from the place of connection. Is this going to get me more connected, more trust, more of a sense of confidence from my clients? And can I do it in a way that also maintains my boundaries? I do tell my clients, ask me anything. And if there's something I can't answer, I'll let you know. And so my clients ahead of time already know that if they need to ask me something, they can, but I will let them know if they are hitting up against a boundary.
All right, last question that we have time for today. How do you struggle with remaining open to clients whose values you may not share and treating clients who activate feelings of fear or threat? In my case, this might be an anti-Semitic or heterosexist person.
So I think this is a great question. And for me, it's an evolving answer. For one, I think there are some clients and some clinical relationships that cannot withstand the microaggressions, sometimes the macroaggressions, that cannot withstand the level of threat, right? Because if I feel unsafe or under threat, I'm not going to be a very good therapist. So first, I think we need to evaluate how threatening and uncomfortable the relationship is, and if I can move past that as a clinician. Once I make that determination, then it's important for me to figure out, are there places of compassion where I can connect to this person? So beyond the heterosexism, beyond the anti-Semitism, is there a place of pain or suffering in them that I recognize because I also have experienced pain and suffering? And will that place allow me to move into greater relationship with them, even if I don't share their values, even if their beliefs are very different from mine? Can I work from that place? If I can't work from that place and I can't find any spaces of connection, then this may not be the client for me.
All right. Thank you so much, Dr. Green. Unfortunately, everyone, that's all the time that we have allotted for question and answers right now. I'm going to go ahead on to our evaluation portion. This is a link to our SAMHSA required evaluation survey, and completion of this survey provides us with information that we can pass on to SAMHSA and that can assist us in planning future events. If you do need your certificate of attendance for your records, you can be redirected to a place where you can download that certificate of attendance upon completion of this survey. Just allow about 5 to 10 seconds for your browser to redirect you afterwards. As people are clicking on this or filling things out, Dr. Green, do you have any closing remarks?
Just thank you so much for spending this time with me. I hope that there's been something useful offered, and I wish you well the rest of this day and for the rest of your weekend.
All right, thank you so much. That is going to conclude our webinar event, everybody. Thanks so much for your attendance, and thanks again to Dr. Green for a wonderful presentation.
Thank you.